Dr. Morris, first of all, I would like to ask you about the concept behind the development of the constraint-induced therapy.
Yes, so the constraint-induced therapy protocol is based on two theoretical bases. The first is a behavioral mechanism that deals with learning not to use a weaker extremity after you have experienced an injury like a stroke. During the early phases of recovery, it's very difficult to use the extremity, and people are negatively punished for trying to use it, so they compensate. And over time, they learn that the compensatory movements, the better movement, and using the more affected extremity is not successful, so they quit using it. And this was demonstrated by Dr. Taub, the developer of the concept, with animal research. And we do find it to be the case with humans as well. The other concept has to do with neuroplasticity. And we know that the nervous system is modifiable even after an injury like a stroke. But it takes a great deal of training to induce these changes in the nervous system. So this is the type of training that's needed is usually quite more extensive than what is usually received in a traditional rehabilitation clinic. We're talking about the type of training needs to be many hours a day for consecutive days over a period of a couple of weeks. That's what CI therapy tries to do, tries to get use of the weaker extremity in a concentrated massed practice pattern for a 2-week period so that we can literally rewire the brain. So there are two separate mechanisms. One's behavioral, one of them's more physiologic, but they influence each other. The negative learning prevents people from using the weaker extremities so they don't get the neuroplasticity. When we can overcome that negative learning, it makes it more possible for them to use the weaker extremity and promote the neuroplasticity. When the neuroplasticity starts to occur, it encourages them and they see better results, so it helps them overcome the negative learning behavior. So they work together, even though they're separate mechanisms. Okay?
And what is the most important difference between CIT and other rehabilitation therapies?
Well, there are three things that I think are probably behind making CI therapy unique to more traditional rehab. One of them is the way it's delivered. Now, when we deliver CI therapy, it is usually a 2 or 3 week protocol, and when patients sign on to do this, they work around the clock with their rehabilitation. So it's not only just coming to see the therapist where they are using their weaker extremity and using the restraint. They're using it all of their waking hours for those 2 weeks. That's rarely done in rehabilitation approaches. This emphasis of focusing on what happens outside of the therapy clinic is also something unique about CI therapy. We tell patients when they start the therapy that what they do while they're away from us is just as important as what they do under our supervision. So that represents a shift in the way of thinking of delivering rehabilitation. And then the other really unique aspect of CI therapy is the heavy use of behavior management strategies. So what we do is we work with the patient to make sure that they're using their weaker extremity on their own while they're away from the rehabilitation clinic. And we use very specific behavior management strategies to do that. Like, we contract with them about when they're going to wear the mitt, when they're going to use their weaker hand with their everyday activities. We expect them to keep a diary so they can report back to us how this is going. And we use very specific problem-solving strategies with them to help them overcome the barriers of using the weaker hand during that 2-week period. So the behavior management strategies also make CI therapy quite unique, and also makes it very exciting because those strategies could be used with other forms of therapy very effectively as well.